Hello, and I want to welcome you all. I want to welcome to everyone from the Department of Psychiatry, the faculty, staff, and trainees. I'd also like to welcome everyone present from other departments and other medical center programs and School of Medicine programs. We are happy to have you join us. While most of us have been involved in some dialogue at home or at work around social justice over the past several months, today marks the formal kickoff of the Department of Psychiatry's strategic action plan to intentionally and directly address equity, diversity, and inclusion among ourselves, within our programs, in our department, and on our campus. There has been much discussion and planning around what is the right way to tackle the problem of racism in our lives. Many have asked, what are we doing? So I would like to briefly share with you our simple plan, well, complicated plan, but short. And I want to start by saying racism is a problem for all of us, and the solution lies with all of us. We all must be engaged, accountable, and intentional on how we move forward. Today, we begin with a history lesson. Why? Well, because we all need to understand that racism is everywhere, and bringing it to our doorstep will help us realize it, understand it, and purposefully promote action to eradicate it. The department actions included the few following things. In September of 2019, we formed our diversity committee, chaired by Dr. Anique Forrester, a member of our CL consultation liaison team. The committee serves as a reservoir of ideas, facilitation of communication and collaboration, and provides the avenue to meet and interact around the difficult issue of racism. Anyone who's interested in being involved or for a consultation may contact Dr. Forrester. Then, following today's kickoff, we will be conducting 2 leadership workshops to assist our department leaders in how to have these difficult conversations and how to establish a safe place so that these conversations can occur. It is only from the top down and from intentional conversation that we will be able to begin to create real action that will lead to true and lasting change. All faculty have also been provided with a copy of White Fragility, an excellent, thought-provoking, and eye-opening read around why it is so hard for white people to talk about race. It is truly life-changing, and I encourage everyone on the call, if you haven't had the opportunity to read it, please do. And from there, we are hoping for a trickle-down effect, including every person working and receiving care within our walls. Training curriculum, recruitment and retention of faculty and staff, and how we conduct research and by whom will all be critical topics of focus. And with that, I would like to introduce our guest speaker. Time permitting, we will take questions at the end through the chat function at the bottom of your screen. I also would like to let people know that this presentation is being recorded and will be available in several days on the Department of Psychiatry website landing page. Dr. Chuck Callahan is the Vice President of Population Health here at the Medical Center. He began his career as a pediatric pulmonologist, working for 30 years in military, in emergency medicine, and in hospital administration. More recently, Dr. Callahan has become deeply involved in issues of global and community health, including working on systems of care for patients with Ebola in Africa. His recent experience in healthcare leadership has focused on the transformation of the concept of health from merely the absence of disease to the promotion of health and well-being and the role of healthcare systems in positively affecting the social determinants of health. As a resident of West Baltimore community, Dr. Callahan has become an active community advocate in the Southwest Partnership and has had intimate experience living in the very community that we serve here at the Medical Center and School of Medicine. His talk today is This is Baltimore, the Impact of Historical Structural Racism on Health. Please welcome Dr. Callahan.
Thank you so much, Jill. Thank you. And I'm going to look to you, Jill and David. I can see you on my screen to make sure things are moving along okay. That introduction, thank you so much, Jill, makes me sound a whole lot smarter and a whole lot braver than I really am. And it's just very humbling to be able to be here. Of course, leave it to a baby boomer to not figure out exactly how to work the technology, but hopefully we can go ahead. We've had the privilege of presenting this in a number of settings. This talk for the last year, it's a part of every newcomer's orientation. And this year, the honor of being able to speak to the new residents and fellows with the same topic. And usually we really make the justification for this on 3 points. Number one, we have to understand our patients in context. The second is we really want to understand the connection and build connections with our patients. And often I'll make the point that it's not just our patients we need to connect with, and we'll come through this over and over again. We need to figure out how to connect with a lot of our workforce that is also, or who are also residents of West Baltimore. We'll talk a minute about communication, but I'm going to add 4 things to this today to really highlight what Jill just said, that I think this is a time in our history after the death of George Floyd and so many others, and a general arousing of all of our interest in this, for us to sort of commit and ask the questions. And I started this journey. People say he's an expert on the history of Baltimore. I've been in Baltimore 4.5 years or so. I am a student of Baltimore. And one of the things we should take away with this is to become students of the city where we live. So we're constantly on this journey and really constantly learning. And I used to look at the problem and say, well, this is interesting history. I love history. I think it's really interesting. And then I think I moved to, gosh, there's a problem here. What should we do about it? And I would say in the last weeks, quite frankly, the last weeks, it's much more about me. Because the problem begins with me recognizing the very things I've never paid attention to. And we'll talk a little bit about that as we go through. I mentioned communication, and I don't know that everybody knows this, but when you go across the country and you ask people, who do you trust? What profession do you trust? What group do you trust? Year after year after year, as long as they've done these polls, right up near the top is our nurses, medical doctors, healthcare professionals. So that means when you're in a tailgate party, and everybody remember we used to have parties where we all gathered, but when you're in a setting like that and somebody says something about the way those people, why don't those people do something? You know who they're talking about. I know who they're talking about. We have an opportunity to step forward and make the case. This is a lot more complex than it looks. The resident who said one time when I was there here in Maryland, they didn't come to their appointment again. I guess they just don't care. We need to be able to speak up and say, wait. It's a lot more complex than they don't care when you think about how many buses it would take to get here and so forth. So this is an opportunity for us. Context, connection, communication, and I would say commitment. Another part of that commitment is this rising recognition of medical students and healthcare providers as activists. That first name on the column there is actually my niece, who's a medical student in New York, who I opened the page in Time magazine back in November, and there's an article, and she starts it out, and she's just really made a reputation of trying to become an activist in healthcare, advocating for the policies and so forth, of the kinds of things that we can speak to because of the background that we have. Well, here's my background, my bias, what I come from. I spent 30 years in the military, as Dr. Rockbeisel alluded to. And the thing about the military is that everybody has a house, a job, an education, and access to free healthcare. So while I was in there, I was semi-oblivious to the fact that there were differences between healthcare outcomes and everything else. In fact, some of the earliest papers that identified that infant mortality is unrelated to the color of your skin, because up until that point, if you were a Black infant, you were much more likely to die. And people were beginning to dream up some things about why that would be. They're more fragile, something else. We know it's a whole lot more complex, but this is a 1992 paper, 15,000 kids born in a military hospital on the West Coast. And it was the first one to begin to identify, yes, there are things different. It's not related to anything that we could talk about in terms of race, the social construct of people who have dark skins and then attributing diseases to them. To go back to the military, I was in 14 years. I went home finally because they told me I can't do it anymore. 30 years is the law in this country, and it's a good law because you don't want a bunch of old soldiers banging around with time on their hands, fomenting all kinds of things. And so in the year that I was off, not working at one hospital, that's when the Ebola epidemic happened, as Dr. Rockbeisel alluded to. And I went to went to Sierra Leone in the fall of 2014. And somewhere around Thanksgiving, Paul Farmer, who many of you might know, who was the head of Partners in Health I was serving with, made the real strong case that people die from Ebola not because it's a terrible disease. It is a terrible disease, but the mortality should be like cholera, which is about 1 in 10. And at that time, it was around 50%. And in fact, as you look back on Ebola, overall, there were about 28,610 cases, about 11,309 deaths, about 31%. But the point I like to make is nobody who looked like me died from Ebola. If I was contracted Ebola while I was in the unit, I would be flown back to the United States. I'd go to the NIH. And in fact, that's what happened. But if you died from Ebola, it was in part because it was so rudimentary, the healthcare. That was a wake up for me. And it was the first time, I'm embarrassed to admit, but it was the first time it became apparent to me that the world I lived in and the world that I now live in are very different places. Well, right around that time was when the uprising happened here in April of 2015. And we became aware of the fact, we meaning, I guess, my wife and I became aware of the fact that in the inner city in the United States, those same disparities exist. And we'll talk about a couple of those here. But reading the Washington Post, we lived down near Washington at that point, and others began sort of this journey for us about understanding where these conditions come from, why they're there, and then ultimately what we as health professionals can do about that. The journey takes us the next step to this thing called the dot map, which I really find a really valuable resource. As a quick aside, we're going to distribute a handout after this that has the slides on it. But in the bottom corner, if you'll look here, this little icon of Baltimore is a link to either the website or the reference largely that this all comes from. So you can do some of the background reading. The dot map is from the 2010 census, and it's got a dot for every person in the United States color-coded by race. And white or European American is blue, and green, African American or black is green. Red is Asian American, and orange is Hispanic American. And from this view, you can sort of see different parts of the country, the South, and you can start looking at Texas and seeing more Hispanic American, and then you look kind of in the Northeast and you see sort of this blend. But the beauty about this is you can zoom in on every area of the country and begin to see sort of some patterns. Here's Baltimore. So when you zoom in on Baltimore, the green is African American, the blue is European American or white, the red is Asian American. This is the original Chinatown. Right here, this triangle, we're located sort of in this area. Pay attention to this line because we're going to come back to that. That's Martin Luther King Boulevard, and look how cleanly it sort of separates things. And the other line we're going to come back to is this. This is Druid Hill Avenue, and we're going to talk a little bit about, because this area from West Baltimore Street to Druid Hill Avenue and out was old West Baltimore, which was one of the places you could live if you were African American, really up to the post-World War II period. If you zoom in a little bit more on this, you'll see even more clearly kind of where we're located in both the downtown and the midtown campuses, kind of right up against the Martin Luther King Boulevard, what some researchers call a vacuum border that separates one part of the city from the other part of the city. And if you've ever drawn on that, a lot of people will say, well, the reason it has 6 lanes and 3 huge medians is because we need to get traffic in and out of the city very quickly. Of course, if you drive on it, you realize it's not too quick. But it represents, as we'll come back to, something of a vacuum border that in some ways is probably there intentionally to separate different parts of the city. Why does this matter to us? Lawrence Brown was the first one to publicize, a professor at Morgan State, this idea of the white L and the black butterfly. Here you can see the purple is African American or black, and then lighter colors in the middle. And you can sort of see this representation of an L in the middle, and then what he described as a butterfly on each side. And this map, this dot map, this map is important to us because pretty much any health outcome you want to look at, and we'll go through a couple quickly, in Baltimore City follows this map. And you have to wonder if, on the first hand, we know that a lot of these outcomes are not specifically related to the genetics of having brown eyes or melanin in the surface of your epidermis. Then you have to ask yourself, then why would the health outcomes be so different where races particularly live? So we're going to go through this, and we're going to talk a little bit about this idea of structural racism, the normalization, legitimization of an array of different dynamics, history, culture, institution, interpersonal, that routinely advantage whites while producing cumulative and chronic adverse outcomes for people of color. Let's stop here for a minute and just acknowledge the fact that I had a really hard time getting privilege into my head. I've had a really hard time being able to begin to talk about what does whiteness mean as an artificial construct, because quite frankly, I'm not white. I'm Irish. And those are difficult contracts. And then the third piece is to begin to recognize this idea of racism and how it might directly apply to me. Because my first response is things like, well, I'm not a racist. I have friends who are black, all the kinds of things that you hear. And actually, I'm glad you referenced white fragility because it kind of calls some of this out. But the thing I had to acknowledge is this, and we'll come back to it more than once. My skin color, and quite frankly, my gender, but that's not the topic of today's discussion. My skin color is an asset for any move I was educated to want to make in my entire life. My skin color is an asset. And that's the system that we live in. And we who look like me, demographics, we have to acknowledge that is the house we live in. I am responsible for the house. I didn't build the house, but now I live in it. This is the house I live in. And to Dr. Rockball's point, this is what we got to begin to take on. So here's poverty and the black butterfly and the white owl. And you can see the highest concentrations of living below or near the poverty level are the darker red. And you can see this. This is O'Donnell Heights on the far right side, which was an African-American housing area that was built distinctly away from any white neighborhoods to support the war construction, Martin Aircraft and other that was down near Sparrows Point. This is affordable housing by rental housing, and we'll talk a little bit about the fact that this is highest levels of home ownership, and this is our house affordability, and this is the rental as it goes out into that black butterfly again. This is from the health department. High priority food areas, a little bit fainter, but you can see that a lot of these areas, we used to term them as food deserts. We're increasingly using this term as a healthy food priority area, but you can see they sort of follow those same kinds of patterns, and you can kind of clearly see where they're not, where those food deserts are not, or those high priority food areas. Here's violent crime and the butterfly, 2018 and 2019 on the bottom, and then this cumulative 2010 to 2019 that's the murder rate in each of those, the homicide rate. And you can see a very, very familiar pattern. Again, what you can also see is where it seems to be not, for any number of reasons. This is violence and vacant buildings. And vacant buildings is a separate long discussion. In Southwest Baltimore, out our backyard, 35% of all houses are abandoned. And if you go north along this corridor right here, it's 0.1% are abandoned. And so it tends to follow also in those areas for reasons we'll come to. Here's a pediatrician. This is asthma hospitalizations on the left and household income on the right, and there's a very close correlation. Asthma hospitalization is preventable largely as a peds pulmonologist. If we have the right kind of care, the vast majority of asthma hospitalization is a preventable disease, and it happens because you don't have access to that kind of care, and there are other housing issues. This is pretty early. This is just 4 months of COVID data. And one of the questions we'll start asking ourselves is this going to follow the same pattern? We see a little bit about where cases are, but then we can kind of see an interesting pattern on tests and then the test positivity rate. And I think because this is a little bit different, it's going to be hard to track it. But I think we need to watch it and ask ourselves those same kinds of questions. Here's another example of health outcome, and we'll just have a few more of these before we get on to the why did this happen. This is the contrast in infant mortality between the top of the white L, which is on this source, which is a great source, by the way, the Baltimore Neighborhood Indicators Alliance, and you see it there. There's a link on this slide for it. It tells you the infant mortality in the Roland Park area versus Poppleton, which is right at our back door, just north of West Baltimore Street is the Poppleton neighborhood. And at least back in 2017, this marked difference. I want to tell you that there's a little area for hope, Be More for Healthy Babies and other efforts. This area right here is a concentration area of Be More for Healthy Baby and Promise Heights. And they've been able to drive down that infant mortality rate somewhat significantly, I think, in this period of time. And I think it's continued really throughout the city. So there's hope. And I always put that in there just so that we don't forget that. Life expectancy is another thing that tends to follow the black butterfly and the white owl. And again, you can see this sort of familiar pattern in terms of life expectancy. And here's the key at the bottom in terms of how long you live. But another way to look at that is like this. This is Eddie's Supermarket. I'm sure many of you know where that is, up on Roland Park Avenue. I go there periodically, hopefully not while I'm hungry, because I usually end up buying something. I have family members that live up on the north side of Baltimore. And then if you travel all the way down to right at our back door, JWK Liquors is on West Baltimore Street, just beyond the Biopark. And I live in that direction. So that's why I know where it is. Those people think that I know for another reason. It is a 10-minute walk from here, just for reference. But if you start up in Roland Park and you look at it, there's a life expectancy of 84 years. 78% of the population is European American or white, and the median household income is 113,000. And then you travel down to Poppleton, or the area right there where that liquor store is, life expectancy of 67 years, 82% Black or African American, and the median household income is 20,000. And just for reference, that's 7 miles, 17 years, and 17 minutes, and 17 years off of your life expectancy, or 1 year of life lost for every minute traveling south. And that's our city. And you can do that in Boston, you can do that in Washington, you can do that in New York, pretty much everywhere you go. This proximity of concentrated areas of poverty with impact on health, very close to areas that are not. And so you say, well, where does this come from? It's important to know, as we look a little bit into history, that Baltimore was not always this way. So in the area, the years before the Civil War, looking back at the history of Baltimore, Baltimore had one of the largest concentrations of free African Americans or Blacks in the country. In fact, and some people think it was the highest right before the Civil War. Of 26,000 Blacks, only 2,000 were enslaved people. So they were very comfortable with sort of a free population. And it was among, in addition to being among the largest in the country, if not the largest, pretty much Blacks were living and African Americans were living in every community in the city. So this was really pre-Civil War. Lots of things changed with the Civil War, and in particular changed with the Civil War and the period after it. It's fascinating to look at the history of Baltimore, because those of us who are from New Jersey in the north neglect the fact, or don't recognize the fact, that Maryland was very much a southern state. It's below the Mason-Dixon line. It was very sympathetic to the Southern cause. Troops were enlisted from Baltimore City to Confederate regiments that then marched south. And as an effort to keep Baltimore under control during the Civil War, President Lincoln put into prison at Fort McHenry the mayor, the police commissioner, and the chairman of the police board, after some events we'll describe in a couple of minutes, and then directed federal troops to set up gun embankments on Federal Hill. And they were aimed at the downtown Baltimore area, particularly Monument Street, where some of the mobs would form that would then kind of do some of the damage that they've done. So it was an uneasy truce between Baltimore and Washington all during the war. Then when the war ended in 1865, we entered into this glorious period of Reconstruction, 1865 to 1877, when the African Americans, the Blacks were freed, the slaves were freed. W.E.B. Du Bois said, the slave went free, stood a brief moment in the sun, and then turned again towards slavery. And at the end of that period of time, the Compromise of 1877, Rutherford P. Hayes, the Republican candidate, had lost the popular vote, but 3 states pledged to give him their electoral votes if he would agree to move all federal troops from the South and give over control of the southern states again to the Democratic Party, which at that time was the party that was preserving really white supremacy and white rule in the South. And that happened, and it was the beginning of the Jim Crow laws. It really took almost over 100 years to kind of get back on track. What most people don't realize when we think about Baltimore is Baltimore was the site of the first casualties of the Civil War. Fort Sumter had happened the first days of April of 1861, but on April 19th, 1861, troops from the 6th Massachusetts Militia, responding to the president's call, came down from Philadelphia, stopped at the President Street station, disembarked, and had to take streetcars down Pratt Street to get on the B&O Railroad at Camden Yards. And as they came through the city, they were met by a mob that led to a riot, soldiers firing, the civilians firing, and in the end, 4 federal soldiers died, 36 were wounded, 12 civilians were killed, and hundreds were wounded. in the crossfire. And those were recognized as the first casualties of the Civil War. And they didn't happen out west. They didn't happen in the South. They didn't happen in Gettysburg or Antietam. They happened in Baltimore City, within walking distance of where I'm sitting. And it just tells you a little bit about the sentiments of the city and the city where we live and what might have shaped the future as we kind of went forward. As people migrated to Baltimore, they tended to settle in different areas. And you can see here, this is a great paper you have a reference to called The Slums of Baltimore, but looking where the Irish and the German came and the Poles settled, the Russian Jews and the Italians along the east bank of the Jones Falls, which is where Little Italy is today. But the African Americans were constrained really to three areas. One at Hugh Street, which is where Sharp Lendenhall neighborhood is now. Pigtown, west of Camden Station. When they were driven there, they built the Camden Station, the bigger Camden Station train station. And then Biddle Alley, which you can see up here, we'll talk more about, which became the heart of West Baltimore. But the first people that moved up there were domestic servants to care for the folks in the wealthy white neighborhoods in the north part of the city. When people looked at these slums, particularly Biddle Alley and Pigtown and others, they typically attributed this to squalid and criminal behaviors, a squalid and criminal population, rather than really the terrible health conditions. And in 1911, the highest concentration of tuberculosis in the city was in Biddle Alley, which was on Biddle Street, which is now sort of under where Samuel Coleridge Taylor School is located. And you can see the location of Biddle Alley relative to the Midtown campus. It was pretty close by, although that area of the street is no longer there. Well, that's the way things were. And this neighborhood in the 17th Ward, the political 17th Ward, is where African Americans or blacks were allowed to live up until 1910, because no one really ventured or no one successfully crossed the line until George McMencken. And George McMencken in 1910, a lawyer who was one of the first graduates from Morgan State College, one of the first blacks to graduate from Yale Medical School, moved with his family and 4 daughters across from this primarily black neighborhood over to 1834 McCullough Street. The significance of which was that was one of the first places that a black family lived in this area of Utah Place, which was really the upper middle class white neighborhood in Baltimore. The family suffered threats, vandalism, harassment, violence, but they stayed put. And it led the city to establish the first racially designated blocks rule in the city. And the rule said that you could not move into an area that wasn't more than predominantly 50% or more your race, and essentially made it the city ordinance that you could not mix races anymore. And that held for about 10 or 20 years, as you can see here, till the Supreme Court overthrew it. But to the north of the city during that same period of time, the Roland Park Company was settling what was then largely farmland and designing this idea of the suburban neighborhood. And the first strip mall really in the country, some people think, is right there on Roland Avenue, the first one that was established. The thing that's interesting about Roland Park Company is all of the papers that they kept have recently come to light and been donated to the Johns Hopkins Hospital, and a lot has been written about it. Sorry, Johns Hopkins University. A lot has been written about it, and you can see that link there for it. The way the covenant read at the time it was established was that you couldn't sell your house to someone that didn't look like you. Specifically, at no time shall the land included in said tract, or any part thereof, or any building erected thereupon, be occupied by any Negro or person of Negro extraction. This prohibition does not, however, intend to occupancy by a Negro domestic servant. And that was part of the covenant that you signed when you agreed to buy a house in those neighborhoods that you see here. Now, that went on for a long time until it was also ruled to be illegal. But I will just make a point that when I moved here 4 years ago and looked at houses, for example, in different neighborhoods, including the one that we're in now, the first real estate agent showed me all of the neighborhoods that a white doctor would want to live in. And then when I asked a little bit about the Union Square neighborhood where we live, she sent me the crime report without really saying another word. And then told me in a subsequent email she wouldn't take me there after dark. And so we got a new real estate agent. But that is the way these kinds of rules continue today, I think. And there's a couple of other research papers we don't have time to talk about that have demonstrated that. So that was the second R. We talked about racially restricted blocks. We talked about restricted covenants. A lot of people are familiar with redlining. I think we forget what this was really all about. Before the Depression, there were up to 900,000 new house starts a year. When the Depression hit, by 1932, there were 1,000 house defaults a day. And by 1933, 50% of all mortgages in the United States were in default. So half of houses, and it was contributing to this ongoing depression. So in 1934, the National Housing Act was passed and the Federal Housing Authority. And one of the first things they did was set up the Homeowners Loan Corporation. They wanted to completely redo how mortgages were written. And so they sent out surveyors to 239 cities around the United States, one of whom was Baltimore, and they rated the different neighborhoods based on these 4 ratings. Green was best, blue was still desirable, red was definitely declining, and red was hazardous, and yellow, as you can see, was definitely declining. And the literature, the specific surveys on why they attributed this based on who lived there and what the housing stock looked like are all available online too with this link that's here. And you zoom in a little bit more, this was all industrial area, so it wasn't rated. You can see this pretty much closely follows the black butterfly that we talked about. The only higher rated tended to be sort of in the top part of the white L. This had not been really developed for housing as much at that point, although it has since. And we're not going to talk about gentrification, but you just kind of wonder about the transition that happened in these neighborhoods. And the medical center is sort of located in this rough area, this area right up against that housing area. That's the third R. The fourth R, we'll talk about our roads very quickly, and we'll go through this. Many people are aware of the fact that there were plans made in the 50s as part of the Eisenhower highway system to run a connector from Route 70 over to Route 95. One option was to run right through the center of the city. The other option was to swing this in a flyover down along the harbor, and many who live there in Fells Point and other are very thankful that this got killed. This is one of those examples where the white community and the black community came together against this, but the white community has a powerful voice, and none of these routes on the east side were built, but this one was. So this 1.5 mile stretch of what is termed the highway to nowhere, everybody I think is familiar with. But I think what we may not be familiar with was the fact that it powerfully divided a really vibrant black community. 971 houses were bulldozed, 62 businesses, 1,500 people were dislocated. And there's a pattern of that through the city, of which this roads is really just one piece. Another thing I haven't really talked much about before when we've talked about this is something we're just sort of slowly awakening. In the years after the World War II, while the city was still very segregated in terms of where people lived, it became a common real estate practice to move one black family into a white neighborhood. And then for real estate agents to go house to house, give their card and tell stories of how the neighborhoods are going to rapidly decline. And so the white people living in these neighborhoods, fearful that they were going to lose their life investments, which was obviously in the real estate, would very often leave. And then the house would be financed and mortgaged, to an African-American family, because the housing stock was so limited. This was the best they could have, but it was a very high interest rate, and it was also a very high cost of the house, sometimes 100% higher than the house value. And there's a lot of literature out on Edmondson Village as being an example of block busting. But the other one, really, quite frankly, is Fulton Avenue. Those of you who go up and down Fulton Avenue, you'll notice a median strip in the middle. And until this began, the east side of it towards where we live was all African-American, and the west side was white, until this block busting began and African-American or black populations crossed Fulton Avenue. Last one, and this one's still ongoing, this idea of revitalization, of the revitalization of the harbor in the 50s, then the building of the inner harbor, and 1976, the bicentennial with the sailing ships that came, and then the hotels that have been opened in more recent years, these high-end luxury hotels downstairs and downtown. The impact of these, I think, is not clear yet to us as we go forward. So there's lots more about the history of Baltimore, but what I hope is that we can recognize that if you live in one of these areas and you can't live anywhere else, and then you can't get a mortgage to buy the house where you live, you're constrained to have to rent. And in addition to that, if you're from a family at the end of the 19th century, you'd save your money to buy other family members, perhaps out of slavery, or in the middle 19th century. So your expendable income that people like me might have spent on a house really wasn't available to you. And when we talk about generational wealth that passes from parents to their children, it's denied to a certain population in our city, or has historically been denied. And when we think about what we should be doing, those are all things that we should be aware of as we go forward. A couple of other things. I mentioned this idea of a vacuum border. On the left map here, the green is African American, the pink is European or white. The darker the shade, the greater the percentage. And you can just sort of see that yellow line is the Martin Luther King Boulevard on both maps. The right one is household income. With the darker the color, the higher the household income. And again, there's an article that's linked here as the idea of a vacuum border that separates area of the city, but it couldn't be a whole lot more distinct, I think, when you look at it this way. And it really should raise questions in our mind as to why the two sides of the city are so divided right within a block of where we live. One more thing when we're looking at maps is to talk about potential progress, but this is really a two-edged sword. On the left here, you see a 1970 Baltimore segregation. Each dot represents 10 people, and you can see in 70 it was still a relatively segregated city. And then you move forward to 2010 on the other side, and you can see that there seems to be much less segregation. But part of what's hidden in this whole thing is what happened to Baltimore in the 50s and the 60s and the 70s. There's a whole lot of literature on what happened to Baltimore after the riots, after the death of Martin Luther King, with increasing flight of all the middle class out of the city. So all of the middle class that had the opportunity to sort of move from what was old Baltimore, sort of in this triangle or this square here, out into these suburbs, and really the dissolution, the dissolving of these neighborhoods that had been intact and healthy neighborhoods, and the death of the commercial corridors like West Baltimore Street, like Washington Boulevard, which is on its way back, like Pennsylvania Avenue, which was considered, and some people call it the Harlem of the South. And now those are largely vacant buildings and not very active businesses. This leads us to this concept of implicit bias. And when we're talking to healthcare professionals and we're starting kind of our career, or even in the middle of it, to begin to ask ourselves sort of hard questions about implicit bias. And this often will get us in trouble. This test, by the way, is free. It's online. You can click on Project Implicit, or you can look it up yourself. And these are the tests that are available on the site. And what they do is, if you've never seen it before, I would ask for a show of hands if I've had everybody in front of me, but they show you a face, and then next to it, they show you a word that's either positive, quote, or negative. And they ask how quickly you can associate the words with what you're looking at. That's for the skin tone and the race one. For example, for the gender one, they'll do the same thing with men's faces and women's faces, and then they'll click next to it words like corporate, family, children, business, and see how fast you respond. How easy is it for you to associate a word like corporate or business with a female face or a male face, as the case may be? And then what it tells you at the end, and it takes about 15 minutes, is that you may have a bias against or for one group or another. Now, bias is like air. It's like breath. We all have bias. And the first step in this journey is to recognize that we're all biased against something. And that very often we're unaware of how that is influencing us, because bias leads to prejudice, which is on the basis of that bias. I begin to talk a little bit about groups and lump them together because I have this bias against them. I'm willing to confess to this group something that's a little hard for me to come to terms with, but I was not allowed to ride the subway when my South Jersey home. We would go into the city. I could take the bus, but not the subway. And what was imprinted in me, and it was only the last couple of years I realized this, was a fear of people that were Black or African American. And that sort of raised its head again in different incidents since I've been here. And it's had for me to work through. And I'm being very transparent and very clear with you. And when I took this test, it was an early indication that you may well have that there. These are things that we learn. And again, they're not necessarily like only bad people are that way. We all carry those somehow. That's how we survived from prehistoric times, not getting eaten by by saber-toothed tigers and everything else. We just have to admit that it is active and going on in our lives, and something we have to kind of grapple with, because beyond prejudice, we act on that. We act in discrimination. We say that I don't want to take care of this person because of X, or I'm afraid to go here because of that, or we cross the street when we see somebody coming in a way that's the thing they term sort of a microaggression. And then in the end, if we happen to be the group that holds power and we can implement power, we sort of steer into racism. And as I said at the very beginning of this, we'll revisit here a reminder that my skin color and gender, but really both of those, have been an asset for any move in my life I was educated to want to make, and almost any research you look at is going to confirm that. I mean, in terms of how I got into college and what my name looked like, and there's a lot of papers about that, about whether I'm more likely to get pain medicines in the emergency room or my children are more likely. There's research that really points to that. And we all instinctively deny it, and that's fine, but we have to begin to acknowledge. And another wake-up call for me was a friend of mine with a car that was a little bit nicer than mine in the city. I have never been stopped by a police officer. He's been stopped 21 times. And why is that? I mean, he's black. It could just be the car. It could be a number of things. But it just makes you sort of wonder, that's kind of what privilege means. I don't have to worry about whether I'm going to get pulled over. And if I do get pulled over, I could just pull out the I'm a doctor at UMMC card or whatever it happens to be. But anyway, nested in this is stuff that we have to come to terms with. And I really love the Department of Psychiatry, and really, quite frankly, for saying, okay, it's time for us to take this on. We've got to take this on. We have got to figure this out. And it starts individually. It starts by reading books like White Fragility and not throwing it down when you're a white person, as an example. Okay, sermon ended. I'll move on. The racism in healthcare is just another thing that we sort of talk about, and recognizing, as I said before, understanding our patients in context, understanding that this is some of what they carry with them. It has been fascinating to watch how people respond to COVID. I mean, one person walked past our Baltimore testing site last week and said, all of this is BS. I don't believe in it. Somebody else at a testing site drilled me over and over again about what was on the probe I was putting in his nose. He was convinced that the COVID was actually on the probe or some medicine, and was finally someone who didn't look like me who walked up and said, look, there's nothing on the probe. It's okay. It's going to be all right. But we have to recognize that anger and frustration and mistrust are part of what people carry with them. And again, I did not build this house. I'm a newcomer here. I'm a brand new doctor here. I'm just a guy in a necktie at the testing site, but I am responsible for the house I now live in. And I've got to face these things and I think respond to them in a positive way. So we need not to take this personally when it happens on the ward or it happens in a unit. I mean, it's happened to me, working in inner city Philadelphia as a fellow years and years ago. We have to understand that for many of the patients we care for, they carry with them the mindset that they didn't expect to live before 18, as somebody has told me more than once. He expected as a young teenager that he'd be dead before he was 18. And these are some of the things that we have to grapple with, I think, as a system as we move forward. The good news is we come from a profession that recognizes at some level that this condition, this situation that our patients is in, I'm going to be there someday too. And our ability to remember to connect that way and treat them like we'd want our grandmother and so forth is really the essence of patient engagement, and it's becoming engaged with our patients as opposed to just talking about their experience, really getting engaged with them and really getting to know them. And we'll talk about that in a minute or two. So as we look at that engagement and we look at that conversation, we recognize an opportunity that we have living in Baltimore in 2020 that not everybody has. People in South Dakota may never have it. People in Iowa, a friend of mine from Iowa said he never met a person that wasn't white until he went to college. And there are places around the country. But here we cross paths every day with people who are like us. And as Martin Luther King said, they're like us in many ways, but not like us in terms of the way they look. People fear to get along, Martin Luther King said, because they fear each other. They fear each other because they don't know each other, and they don't know each other because they have not communicated with each other. And that's the opportunity that we have. Another author said the single most important factor in changing implicit bias is regular and normal interaction with the groups we have been trained to think of and to fear, to think of with fear. So regular, normal interaction with those we have been taught to fear. And that's an opportunity in some ways, or those who are at very least different than us. That's an opportunity that we have sort of going forward. So if we live in Baltimore, if we work in Baltimore, if we practice in Baltimore, what I say to the newcomers when we have this conversation, if you're here 1 year or 3 years or 5 years, or we retired somebody out of Midtown recently that had been there for 50 years, the longer I'm here, the more often I find people that stay at Maryland for long periods of time, that stay at UMS for long periods of time, because it's really a great place to work. I'm a big recruiter because I think it's been such a great organization. But forever long we're here, we're going to just have to face the fact that at least in Baltimore, our patients and their families over generations have suffered and continue to suffer from structural racism. And we need to begin the journey to ask the question that says, what can we do? And more importantly, where do I start? Where do I begin by recognizing? And it is a difficult, painful journey. I'm just telling you. I mean, I had a heated argument with my wife about privilege that I can picture to this day, as she, a social worker, a little ahead of me, was pressing this idea of privilege, and I'm pushing back, talking about how hard I worked my whole life, like we so often do. And she really called me out and said, how is it that you think that you can define what privilege means, instead of taking what other people are saying about it? And I remember the conversation. It was a wake-up call. And I think we all have to kind of come to terms with that. And that really is the purpose, I think, of this movement going forward, both in psychiatry and elsewhere. Consequences of that are the things we face every day. And we face crime. We face the issue around drugs and so forth. And we see these things as problems, but sometimes fail to see that they represent something else. I've had the distinct privilege of being in clinic with Dr. Weintraub and other people from the Department of Psychiatry in addictions in particular, and talking to them. It changed the way I see people who are addicted. And it was such an important part of my journey now that we're involved with caring for them at the hotel and some of the alternate sites, recognizing that there's a little bit more to this than just this is a person who's abusing a substance. There's a little bit more to the fact that the folks right down the street from me have as their only industry an opportunity that they can see selling drugs, and continue to offer me marijuana as I walk by. I must have that look about me as I walk by the group. But there's more to the story than that. And I think it's important for us to sort of recognize that as we go forward. All of things are important to recognize as we go forward. So let me suggest a couple of things that we should do. And people say, okay, well, what am I supposed to do about this? Here's what I would recommend, 4 things. And these may be things you've already thought about, or maybe things you can kind of rally around. I think we have the opportunity to listen and learn. And what we tend to do instead, just for everybody, and I think you know this, is people will start talking about their experience, and then we'll start talking about ours. We'll start talking about how uncomfortable it is for us to have conversations as a white person, and how we feel. And I think just like when we talk to someone who's grieving or going to the dentist and don't tell them immediately about the last time I was at a dentist, it really doesn't do any good for me to tell you my story unsolicited. So that's the listening thing, and it's active listening. It's talking about how people feel. I was on a call a little bit earlier. I'm involved with homelessness in the city, and it was a conversation about resource allocation. I'm involved with the committee that handles the money coming to the city for homelessness. And when the one guy did his check on at the beginning, we asked how people are, and he said, "I feel angry." And that's an important thing for him to be able to express, and important for us to listen to. And then the other part is learning. And don't do necessarily what I did, and have a meeting with someone who's Black to say, help me understand what it's like to be Black. One of my friends, very gently, a pastor in the city, said to me, I want you to go home and look at your library, because I know you read all the time. And I want you to come back to me and tell me how many books are in that library that were written by women and people of color. And there weren't that many. And so if I'm going to learn, I got to start reading other people's perspectives. And if you wonder what to learn, we'll say it again in a minute, where to start. Frederick Douglass's autobiography is a great place to start. So listen and learn, and begin by self-study and the openness to say, listen, we're on a journey here. We're on a journey. We need to learn this together. The second part is, I think we have an opportunity to stand. I mean, we had opportunities, we were a little bit daunted by COVID, but protests are ongoing in the city about opportunities to look at the way we use funding and other things. And I think there's lots of opportunities for us to stand alongside. I said early on, and I have a activist friend in the city who's been a tremendous mentor to me. He said, Chuck, every time I open my mouth, I'm just an angry man of color. But when you open your mouth, people will listen to what you say. So we have a unique opportunity not only to stand with people, but also to speak. This is Tim Wise, who's considered one of the sort of gurus in the country right now. Speaking, he's got a bunch of different TED Talks and has written a fair amount about speaking to those who will listen. From the position of humility, I'm not an expert in this. I don't think any of us become an expert very quickly. And in fact, one book on relocation says plan to go wherever you live and stay there 15 years. And I know that it's a long journey, but we begin to speak with humility about the things that we know, and we're going to be wrong. We're going to say the wrong thing. We're going to do the wrong thing. And we got to kind of pull up our pants and say, okay, I'm going to get back in the ring, even though I do that. So I'm going to speak with humility, but courage to those people that are kind of propagating things I know not to be true. And then finally, we have the opportunity to invest and enlist. And invest is as simple as saying, okay, I know that my bias inclines me to go naturally to people who might look like me and might act like me and might do the things I do. How can I cross over that and begin to actually specifically look to make sure I'm not missing other people that can do the kinds of things I want to buy near us? You know, whether it's the chicken store down the corner from me or whatever it happens to be. But even more specifically, and we'll come to this in a minute, the idea of investing in people's lives and then enlisting others to join us. Again, it's humility. I'm not an expert in this. We're just beginning this journey, but it's a journey that we can venture on together, and I think it's a critical one as we go forward. And I make a plug. I'm not on the board, and I have no financial interest in this, but sometimes people say, I want to do something specifically, and I say to them, we'll change one person's life. Ann Donovan was a nun that was martyred in El Salvador in 1980, and she said, you know, you can change the world if you recognize that your world might be 2 people or 3 people. Well, here's one way to do it, and here's an organization. There's a couple like this in town where they'll partner you with a small group of, they call it a family, around a failing high school student, students whose high school graduation rate is less than 5%. And they surround these students with a family of supporters who are really just that to them. They make sure they get their homework done and they take them out to get school supplies and so forth. This group has an 85+% high school graduation rate with this group of folks within 4 to 6 years, and a significant number go on to college. You want to talk about a game changer, a generational game changer. This is one of those generational game changers. And more importantly, from a public health or a population health standpoint, if that guy graduates or that woman graduates high school, they're less likely to have all of the chronic diseases that we so commonly see in West Baltimore, less likely to drink, be overweight, use drugs and everything else statistically as a population. But we can begin by perhaps impacting a single life. And the bulk of the volunteers, fascinatingly for this, come from college, medical and health related students. They really do. And I just heard 2 nights ago, they're looking for 100 more volunteers as they spread this program to high schools across the city. The link for Thread is there, and thread.org is also, you can just Google that on your own. Last couple things. That's me as an intern years ago. I was waiting for rounds to begin. That happens a lot. I found this article in 1985 Journal of Pediatrics, which sort of tells you around when I was an intern. And I found this quote in the journal. Each of us bears a personal responsibility to leave the state of pediatric care better than we found it. And I would argue that for all of us, however long we're in Baltimore, we have that same responsibility. We have the personal responsibility to leave Baltimore and the people of Baltimore better than we found them. And the sidebar on this is, through the process, we become more the people that we were meant to be, I think, and we begin to be able to grow and develop in ways that we can't even really begin to understand. One of the great joys of medicine, I believe, having done this for 3 or 4 decades now, one of the great joys of medicine is getting to know people's names and getting to know their stories. I talked to a security guard this week that's helping us on one of our sites. His name's Brian. He has 4 or 5 children. He told me about his story about his children. And then yesterday, or I guess it was yesterday, he came up to me and asked me about one of his kids' diagnosis of COVID. The ability to have that sort of trusted opportunity, but the idea that we learn their names and we learn their stories and we begin to say, you know what, he's experiencing the same kinds of things that I'm experiencing. Names and narratives, I try and remind myself. They matter. They matter to people. And in the end, when you look back on a career in medicine or a career in healthcare, it's the stories that you remember. It's the individual people and the families and so forth. That's the great joy of medicine. But here's the great privilege of medicine. The great privilege of medicine is not just that I get to know their stories and their names and the narratives that are all a part of that, but I get to be a part of that story. I get to be a part of that story as well. I had a cancer diagnosis in 2007, and I was in my own hospital where I was the chief medical officer. People would walk in routinely and say, "Do you work here?" Which means I was not getting out nearly enough as I thought I was. But they would sit down. They would come into the room, and I learned that no one really talks to the patient. Everybody stands at the door and sort of talks in. And finally, one nurse came in, and one nurse it was in almost 2 weeks, pulled a chair over to the bed, sat down, eye level with me, and asked me how I was doing. It was a junior nurse just out of, I know the name of her nursing school because I wrote to the dean of her nursing school. Here it is, decade or 2 decades later, and I remember that story. She had the privilege of becoming part of my narrative forever, and we have that same privilege in healthcare associated organizations. We get to be there for the best days in people's life and the worst days in people's life. But however we approach that, however we're there for them in those moments, we become part of their story forever. And that, to me, is, I think, the greatest privilege of medicine. It's a privilege that we all have. I'm going to pause here. I'm going to put up a couple of books that have been helpful. If I had a second slide, I would put up a couple of other books, and 2 of them would be White Fragility, and another one would be How to Become an Anti-Racist. I'm only partway through the second. As I said, this is a journey for all of us. If you want to start somewhere learning a little bit more about this, I really encourage Frederick Douglass's autobiography. He grew up and labored in Baltimore. So I'm going to stop there if I can. And Jill, I think it looks like you've been dutifully writing down questions. I'll preface everything I'm about to say with the acknowledgement that I'm really just on a journey like all of us are. But thanks everybody for your attention.
So thank you, Dr. Callahan. Chuck, that was great. Clearly, lots and lots of stuff to think about, and we need to continue these conversations. We do have some comments and questions, so I think I'd like to go ahead and give us an opportunity to think about them. The first question came in. Thank you for the discussion. I have a couple of questions. How can we continue to have these conversations, but also provide an opportunity for women and people of color to lead the conversation? Also, expanding these conversations into the community. So Chuck, I wonder what you think about that.
I think these conversations should be led by women and people of color, and I'm a placeholder. I see our role, and I say this about me, I'm in a different place in my career than a lot of folks, a little bit more senior. It may not be obvious, but I am. But I see the role being exactly that, so that to support people of color, women, people from other discriminated against groups, to really lead these conversations and lead in general. I think in our city, in general, we need to have people lead. Those people lead.
That's great. Chuck, if I could just jump in here. Somebody asked if you would put up the book list again, so maybe you could throw that back up again. One of the things that we're doing in the Department of Psychiatry is, as I mentioned in the beginning, we're having leadership workshops to help train leaders on how to have these conversations, and most importantly, how to create a safe environment that people feel like they can share their thoughts and feelings. I have to commend Chuck. You did a phenomenal job of being absolutely transparent about your own experience, your own feelings, your own thoughts that are hard to say out loud for fear of how they'll be heard. And you did a great job. And it's important to create that safe environment that people can. So we're starting some training workshops. One of the resources was, there's lots of resources out there. There's a toolkit called Continuing Courageous Conversations, with lots of suggestions on how to learn this and how to lead it. You can certainly call our Anique Forrester, who is Dr. Forrester, who's our head of diversity committee here, and she can also have some recommendations. You know, Chuck, in response to your answer, if I could be a little devil's advocate, let me just challenge you with, you think women, I agree with the women part, but the persons of color, I have heard this is a white person's problem and white people are the ones that need to talk about it. What do you think about that perspective?
Well, I absolutely agree for some of the reasons that, I mean, there's some great graphics that are circulating around the internet about sort of this progression that we go through, you know, a beginning to recognize, you know, some fascinating literature on the whole artificiality of race in general, but whiteness in specific, that whiteness is an invention of the last, you know, century and a half or so. That's a conversation I think that white people have to be a part of, because I think other people won't, I think people who look like me won't listen. And they still might not listen. But it's a very hard conversation. But when you actually look at the history of where the idea of whiteness came from, it's completely artificial. And then I'll tell you, when you want to really shake up the medical community, begin looking back at all the diseases that we naturally attribute to melanin, whether it's in the iris or whether it's in the skin, and really ask some hard questions. How exactly did you decide that again? Did you just look at somebody? And make those decisions? Those are hard things. And I do think we have a role. That's why I said speak. There is a place for us to speak.
Right. There's another comment here. I am an African American male, and how are we able to express our thoughts? And again, I'm reminded when you said listen and learn, that often when you listen to individuals of color, there is anger, there is rage, and it's hard sometimes to listen to. What thoughts do you have about that?
It is. And I mean, I sometimes feel like such a knucklehead about this because, you know, but one of the things that's happened since the death of George Floyd, one of the things that's happened is that I feel like at least a little piece of me has woken up to the fact that people are carrying an unbelievable amount of feelings about that. And so, you know, I don't know whether, if you come from a theologic background, whether it's God smacking you in the back of the head or something, but the opportunity to ask and then listen to how people are feeling. I mean, listen, healthcare professionals know how, in our best moments, we know how to grieve with people. We know how to let people tell us how they're feeling and just be there for them. And I think we just take that skill set and apply it here. I spoke to someone at Hopkins a week or two ago, and it was my privilege to ask her, it was a week or so after Memorial Day weekend and all of the things that happened, how are you feeling? And there was a long silence on the phone. We barely know each other. And she said, I used to feel good about my son going out and safe for him going out. And now I feel uncomfortable again. What a privilege it was for me to hear that. And so I would say to the person who asked that question, we need to hear that voice, and we need to be quiet and listen to those feelings, just like we would do in healthcare.
Thank you. Let me see. There's another comment. Can you comment on the internalization of racism by racial minorities and the learned helplessness?
Yeah, I can comment on it, although, again, not an expert. There's a whole lot of consequences of the world that we've constructed. I mean, there's a whole lot of consequences of this world, and you can talk about the folks that live near me that don't grow up. They don't grow up thinking that there's anything else that they can do. This church pastor I mentioned, I think, who basically felt like his life was going to end before he was 18, so why should he graduate from high school? And he did. He went on to Poly, and then he went on to Morgan State. And instead of moving away, he moved back into the city. But I do think that we have created a system that sort of perpetuates itself. Like you know, any system is built to give you the results it gives. And I would say that some of that learned helplessness, that is the house where I now live. As I said before, I'm responsible for the house. I didn't build it, but I'm responsible for it now. So what does that look like, and how do we find our way out? I'll tell you, it has to be the voices that don't necessarily look like me that speak to that, and not just my ideas.
So here's an interesting comment. This is one of the disadvantages of having a remote presentation where we're not in a room together and able to see each other and talk to each other. I am asking because during this WebEx, I am not seen or heard. for African Americans, it's always been an issue of white Americans speaking on what we think. That's a real issue. I guess that comes back, Chuck, to what you said. We need to listen and learn. Some of that listening is hard because I know personally, when you start hearing some of this, the history, the experiences, you start to feel awful and guilty, and it's so hard. And again, we didn't build the house, but we live in the house, and we have to take responsibility for it.
Absolutely. I think that's such a great comment, because I'm going to take that away from this, because the folks that are Black on this right now, to not be seen and not be heard, is almost metaphorical. And I recognize that this is a forum where we have to do this, but I think what we do is we have to follow up with the willingness to be able to have these, whether it's small virtual groups. We other departments have done that. I've had the privilege of being able to part of that conversation. And listen, my vested interest is I'm on a journey, and I don't get to where it is that I want to go unless I get help from people. And the way I get that help is by having them sort of tell me truth.
So here's another comment. People of color feel provoked. Don't misplace our expression or passion for anger. Don't be afraid to ask questions after listening. Truth. That's very powerful. Truth. And whoever said that, thank you very, very much. I appreciate it. Chuck, any final comment? Let me see, do we have anything else? How can we specifically address the issue of police brutality and how it affects our patients, especially given the university's relationship with Baltimore police and reliance on prison labor? These are loaded questions.
Yeah, I can't speak as much to the second one. I think to the first one, this is really difficult because, you know, I have friends that are on the police force, or people I know anyway, and this is, I think it's very difficult. But the same way we began this conversation around bias and prejudice, we have to recognize that we all carry this with us. And I would argue that that whether you're a doctor or a nurse or a police officer, you carry bias and prejudice with you. And I think that part of our what we need to do is basically just, you know, to call that. We have to recognize the fact that people of color in general, I would say African Americans in specific, have suffered as a result of this whole thing. Look, in Baltimore, 1 in 3 African American males will end up in prison in some time in their lifetime, and across America, it's 1 in 17 whites. So there's something wrong with that. If you've never watched the documentary 13th, again, it's another eye opener about police and the judicial system. And I think, as Sarah Heminger from Thread likes to say, we've got to call a thing a thing. And our first step is we just got to call a thing a thing. Listen, guys, I was in the military for 30 years, separate long discussion. So I'm very sympathetic. But I also have to recognize, look, we all carry biases and prejudice with us. Only I don't carry the responsibility all the time of deadly force. And I think that's something we just have got to have on the table.
Wow. So I think we've exhausted we've gotten a few comments of people of appreciation. I want to point out, this was our kickoff. This is the beginning. This is not the end. This is the first conversation. These conversations need to continue, but on maybe a much smaller level, which is what I referred to, the trickle-down effect in our department and in our programs. We would like to have people in more intimate settings, have conversations, listen, learn, stand up, speak, invest, and enlist. That's a tall order, Chuck. I got to tell you, I'm not sure how we're going to get to the end, but this is a beginning. I am hopeful. This is something that's been a long time in coming.
Yes,
yes, absolutely. I want to appreciate everyone that logged on. We had over 400 people sign up, 350 showed up. It's been great. Just a reminder, we're going to circulate the slides to everyone that did register. This presentation has also been pre-recorded, and only with Chuck's permission will we post it up on the Department of Psychiatry website for one, and wherever else Chuck might want it. And again, thank you all for attending. And thank you, Dr. Callahan, for joining us today.
And I'll just say, Jill, thanks for your leadership, and thanks to the Department of Psychiatry, who really has played a significant role in my own journey since I've come here. Always, I mean, I've learned so much from the folks that you work there and continue to learn from them. And maybe it's an exciting opportunity for us to talk in the future about GBRICS if it gets funded, the Greater Baltimore
Right.
Committee Crisis Now that will really help, I think, all of our populations. But we can put that on the agenda for another meeting down the road, particularly if it gets funded. So I just really kudos to the Department of Psychiatry and to everybody that is willing to take this much time out of their day to join this conversation. So thank you. And it is a privilege.
Actually, we did have one other request, Chuck. The request came from our chair of our diversity committee. She is soliciting you as a member of the Department of Psychiatry's diversity committee. So take that.
Well, that is humbling. I would be honored. It's tremendously humbling, but I would be honored.
Excellent. All right. Thank you, everyone. We'll end here. Again, thank you, Chuck, and enjoy the rest of your day. Stay safe.
Thank you. Thanks.